Dr. Vijay Pratap Singh
Okay,
for his talk on viral uveitis.
So good morning, everybody. Thank you so much, AIOS, for giving me the opportunity in this academic feast. So there is a generalized notion that uveitis is either idiopathic or it's autoimmune in etiology, and it is going to be treated either by the means of topical steroids or oral steroids. But this is not true. So it was a case of 60-year-old female who presented with the diminution of vision in the right eye, and her best corrected visual acuity in the right eye was 6/18 and 12, and the IOP was 28 millimeter of mercury. On anterior segment evaluation, it was noted that KPs was there and flare 2 plus and cells 2 plus was present. So in the general OPD, the patient was treated with topical steroids and cycloplegics, but this patient turned up after 3 days with increased inflammation of cells 4 plus and flare 4 plus. So the patient was referred to the department of uveitis. And when we evaluated, we found, is there anything missing? Yes. We revisited the case, and what we found that there was the history of fever 10 days before, and these KPs were not fine KPs, these KPs were actually stellate KPs, and there was sectoral iris atrophy at 6 o'clock position, and that IOP was again raised. So this was a telltale story of an infective etiology that is viral. So it was a case of herpetic uveitis which was actually misdiagnosed as an idiopathic one. So these viruses not only presents with this, how we will investigate these patients. We investigated this patient, we did simply AC tap to prove that we were right. And on AC tap, what we found that this was a case of varicella zoster virus which was detected on the PCR of aqueous. So these viruses doesn't manifest as anterior uveitis, they can also cause posterior uveitis, and particularly the group of Herpesviridae family. The most common presentation of Herpesviridae family that we see in our day-to-day clinical practice as a uvea consultant is acute retinal necrosis. This acute retinal necrosis usually presents with multiple or few discrete foci of retinal necrosis in the periphery, which rapidly spreads circumferentially in the absence of antiviral therapy with moderate to severe vitritis, and the most characteristic feature of ARN is occlusive retinal vasculitis predominantly involving arterioles, and this entity gives a typical Swiss cheese pattern. They can also present with hypotony. They can present with increased IOP. And the amount of inflammation in the vitreous as well as retina is intense. So because of this retinal inflammation, this retina is necrosed, there will be multiple tiny holes which gives it a typical sieve-like patterns. And while you are seeing a patient of ARN, there is unilateral involvement. Always have an eye on the other eye because this disease is having a tendency to involve both the eyes. Look for the prodromal features and the telltale sign of previous viral infection in the form of chickenpox vesicles or herpes zoster scars. The diagnosis is mainly clinical, but it can be confirmed by the means of PCR from the aqueous or vitreous. And if the Goldman-Whitmer coefficient is of more than 3, it is the diagnostic of ARN. Retinal biopsy is indicated in the cases of diagnostic dilemma. The disease mainly affects the immunocompetent people, and the most common cause of ARN is varicella zoster virus, followed by HSV, then CMV or EBV. Until unless you are not having the report of PCR, the initial therapy should be IV acyclovir in the dose of 15 milligram per kilogram body weight, but as soon as you are having the PCR reports, and if it is HSV, you should titrate the dose to 10 milligram per kilogram body weight per day for 2 weeks, and after that you will put the patient on the maintenance dose. You can go ahead with the oral acyclovir in the induction phase in the form of 1 gram tedious, and in later on you can go ahead with the 1 gram OD or BD depending upon the response to the drug. The role of systemic steroids is always controversial. If you want to give them after only 48 hours. Prophylactic laser barrage is indicated to prevent the retinal detachment, but that doesn't hold good. And if RD is there, surgery is indicated, but the results are really very poor. The other manifestation of herpes family is progressive outer retinal necrosis, which is usually seen in immunocompromised patients, particularly when CD4 count is less than 50. There is no vitritis or minimal vitritis in these patients, hence because they are immunocompromised, and the lesions typically involves the posterior pole. They are multiple, multifocal, deep, dense necrotic lesions involving the major vascular arcade, giving a typical cracked mud appearance, and the prognosis is really very poor despite using 2 antiviral drugs simultaneously apart from heart because of the retinal and optic atrophy. CMV retinitis is again an entity which is seen in immunocompromised patients, and again the CD4 count is less than 50, and CMV retinitis manifests in 3 ways. The classical one is fulminant hemorrhagic necrotizing retinitis, which presents with massive hemorrhage and exudation around the major vascular arcade, giving its a pizza pie appearance. The other one is a granular form, which is usually seen in the periphery. There is lesser retinal edema, necrosis, and the most fulminant form is perivascular CMV, which presents and looks like frosted branch angiitis. The treatment is in the form of intravenous ganciclovir 5 milligram per kilogram body weight TID for 3 weeks, followed by OD unless the immune recovery is there. You can also go ahead with the oral valganciclovir 900 milligram BD for 3 weeks, followed by 900 milligram OD daily until the immune recovery is there. Sometimes you will have to give them lifelong. Dengue is a disease which is very much endemic in India, and dengue affects eyes also. The disease affection is usually bilateral, but most of the time this is asymmetrical presentation. The most common presentation of dengue is subconjunctival hemorrhage, but the most, just summing up, but the most characteristic feature of dengue is foveolitis, and maculopathy is more commonly seen with serotype 1. Role of steroids is always doubtful. Chikungunya can present during illness or resolution, and it mimics herpetic retinopathy. Anterior uveitis can be non-granulomatous or granulomatous, and retinitis is usually accompanied by vitritis, and steroids is the mainstay of the treatments. So the take-home message is uveitis is not idiopathic or autoimmune only. Detailed history and meticulous systemic as well as ophthalmic evaluation is the key to clinch the diagnosis. These are my acknowledgements, my sincere acknowledgements to my mentor, Dr. Jyotirmay Vishwas, Sudha Ganesh, and Dr. Sudarshan, and my student and a very good friend, Shivangi, and Mr. Saurabh, who has provided me all the images of my patients. Thank you so much.
Thank you so much, Dr. Tomar. It's a very good presentation. I have just one query from my side, actually.
Yeah.
Do you advise AC tap only in posterior uveitis or only in anterior uveitis?
No. If it is a posterior uveitis, depending upon the severity, suppose if I am seeing that amount of vitritis is much more, or it is a pan-uveitis, if anterior chamber reaction is there,
Yes.
then I think it is advisable to go with the AC tap. But if the reaction is only in the vitreous, I think the vitreous tap or vitreous biopsy is important.
Yes. Only in anterior uveitis do you ever advise AC tap?
AC tap actually whenever I have severe dilemmas. Otherwise,
Posterior segment is not involved at all.
posterior segment is not involved, and I am suspecting that either it's a masquerade, like one kid I have seen who was having hypopia and uveitis, and I was thinking that it is maybe because of HLA-B27, but all the investigation came negative and the patient was not responding. At that time I did a AC tap, and I sent that to my mentor, Dr. JB, and what he told me that it was an 8-year-old kid, and what sir told me that actually it was a case of retinoblastoma. So in masquerades where I am suspecting that or something, when the patient is not responding to the treatment at that time, routinely I don't prefer to do AC tap.
So a younger child, actually B-scan is more helpful if we are thinking
No,
of
if I am
a
able to
masquerade.
see the fundus, then I am not going to do, because if retinoblastoma is there, you are able to see the fundus, you can get
yes.
that lesion. But sometimes the media is so much heavy, the vitreous seeding is there, you are not able to look beyond that. At that time I think you should do a AC tap.
Okay.
It is always helpful.
Can I ask one doubt?
Ah.
Sir, is there any role for this prophylactic acyclovir? Suppose the patient is getting recurrent antiviral keratitis. Any role?
I
for
think
how
if a
long?
patient is having recurrences of that viral anterior uveitis, I think it is better to give that maintenance dose of oral acyclovir or valacyclovir for at least 6 months.
6 months.
At least 6 months you should give. If it is coming again and again, that valacyclovir is a safer drug. You will have to give that 1 gram OD.
Yes.
And suppose he is having open angle glaucoma, is there any contraindication for starting prostaglandin analogs?
I am having my glaucoma friends, they say that this is not going to affect.
Exactly.
Recently, I am having one patient who is having that serpiginous choroiditis, and that girl was given that posterior subtendon tricot, but she was a steroid responder, so the pressures were very high. So initially, I was thinking that should I go ahead, ask my friend to go for the trap, but he said, no, we will manage this with AGM, and we put that girl on latanoprost along with the dorzolamide, and it responded nicely.
Thank you, sir.
Okay, thank you.